today we'll tackle the shock syndromes, different types of shock, and then we'll dwell into the advanced hemodynamic assessment and how to do it. Probably before I start that, I will answer one of the questions of yesterday. I think it was Dr. Ismail who asked me about, is there any way we can measure the intracranial pressure with non-invasively? And I did suggest to him the optic sheath nerve diameter measurement. And I just couldn't remember the exact figures that I had to quote him. So this is a picture illustrating after you apply the probe on the eyelid of the patient, usually use the vascular probe, obviously. Then you'll get this picture of the eye globe, and this is the optic nerve. So you measure 3 millimeters from the edge of the retina, and then you measure this width, and this what would count as the optic nerve sheath diameter. Anything above 5 millimeters suggests high ICP. My colleague, Dr. Salahuddin, in her study, which she conducted at King Faisal Specialist Hospital in Riyadh, concluded that more than 0.57 centimeter usually predicts high non-traumatic brain edema in 80% of patients. I hope this answers your question, Dr. Ismail, and we'll move on to the main talk of today. So, shock syndromes. What we're going to do today, we are trying to define the shock, talk a little bit about the pathophysiology of shock, then go through the types of shock, the clinical manifestation of shock, and how to assess the hemodynamics, and probably we'll have some simulation cases at the end. I'm hoping today we'll answer, I think, Dr. Asma's question yesterday to me: how would you assess or know the type of shock in a low resource countries? Inshallah ta'ala, you'll find the answer today. Right, so what do we mean by shock? It was such a difficult question that it needed an international consensus conference to answer this question, which was held many years ago. The main aim was to really unify the definition of shock, not only to use it for clinical purposes, but also to be used during research related to shock. And here they recommended that shock is defined as life-threatening generalized maldistribution of blood flow resulting in failure to deliver and or utilize adequate amounts of oxygen, leading to tissue hypoxia or dysoxia. Blood pressure can be less than 90 millimercury, or it can drop by 40 millimercury from baseline, or the MAP can be less than 65 millimercury. However, patient might present without hypotension. The crucial thing that you need evidence of tissue hypoperfusion is required to fulfill the definition of shock state. So this diagram will illustrate what shock can present like. So patient can present with blood pressure less than 90 millimercury. They can present with MAP of less than 65 millimercury, or a drop in their systolic blood pressure by 40 millimercury from the baseline. But no matter what's the blood pressure, they must have evidence of hypoperfusion. And one of the commonly used perfusion indicator to achieve this is the lactate. So high lactate in the context of shock state is highly suggestive of presence of shock. So the shock can be either reduced oxygen delivery or content, and usually these patients have low cardiac output states, or it can be reduced oxygen consumption. And in this situation, your patient might have normal or even high cardiac output, as we see sometimes with septic shock patients. Now, this is just an illustration between the relation between oxygen delivery and the oxygen consumption. So you see here that your patient would have a huge reserve of oxygen delivery before they reach to a critical point where no matter what the oxygen they are delivering, these oxygen consumption start to drop, and this is what we call the anaerobic threshold, or when the cells start to use the anaerobic pathway to generate energy. And at this point, the lactate in the red will start rising. Now, in septic shock patients, it's quite interesting that these patients start to drop their oxygen delivery as well as oxygen consumption early on in the disease. And you can see that the whole thing is shifted to the right. So the patient will reach to the anaerobic threshold earlier than what they would have done in normal state. And also they will start rising their lactate earlier than what they would do in normal conditions. A few slides about pathophysiology, just to comprehend what happens during shock state. So here we have a cell, and these are feeding vessels bringing nutrients to the cell normally. What would happen during shock, in particular septic shock, you'll have shunting and blockage of main nourishing capillaries. So here, the thrombin, the platelets, will form a thrombus, and that will impede the blood flow through this feeding vessel. Not only that, the distant vessels from the cell will get dilated, part of the generalized vasodilatation, and that will lead to shunting of the blood away from the cell. And that's why in some patients you end up having high mixed venous oxygen saturation or central venous oxygen saturation, because the blood is coming to the cell, but the cell is shutting itself down and not taking any blood. So the oxygen won't be utilized in the cell and goes back to the right side of the heart unused. And
You're muted, Hassan.
So can you hear me now? It seems that I've lost the connection.
Yes, you're audible. Yes, you're audible,
Right.
Dr.
Yeah, okay, excellent. So hopefully you didn't miss much. Okay, so to continue on the histopathology of shock, then there will be inadequate or ineffective oxygen delivery that leads to anaerobic metabolism. There will be large or prolonged oxygen deficit that causes decrease of high energy phosphate stores. And then there will be membrane depolarization, intracellular edema, as we saw, loss of membrane integrity, and ultimately cell death. Right. Yesterday we talked about Ohm's law, so we don't need to spend too much time on it, but we used Ohm's law to deduce this equation that cardiac output equals the difference in the pressures divided by the systemic vascular resistance, and we concluded that MAP is equal to the cardiac output times systemic vascular resistance plus the right atrial pressure. And we can apply the same equation to the right side of the heart. It's just to remind you, I think this is one of the really very important equations in hemodynamics. Just to remind you that we said yesterday, MAP depends on cardiac output and systemic vascular resistance. We know that cardiac output is heart rate times stroke volume. And we know that stroke volume depends on preload, contractility, afterload. And if there is severe disturbance to the heart rate, either tachyarrhythmias or severe bradycardia, then that might lead to hypotension. And we did mention that the systemic vascular resistance, when it drops, leading to vasodilatation, then that will cause hypotension, as we see in distributive shock. Right. So moving on to the clinical manifestation of shock, the earliest manifestation really is the tachypnea, which is unfortunately quite often is missed by the bedside healthcare workers, even though it's the earliest, and sometimes it reflects the start of metabolic acidosis, whether it's due to lactic acidosis or due to hypovolemia, whether it's relative or real hypovolemia. Your patient might develop tachycardia, but we need to keep in mind if the patient is, say, on beta blockers, then they might not present with tachycardia as usual. Then we'll have evidence of organ dysfunction. They usually present with hypotension, oliguria. Oliguria would be really helpful if there's a catheter already inserted for the patient, as the urine output that you get when you insert the Foley's catheter usually reflects really the past hours rather than what's going on right there and then. Altered conscious state is another window of to the perfusion or to the hemodynamics, as we said yesterday. Then obviously if you have lactate, then and you see there's an increase in the lactate, then that would indicate poor tissue perfusion. Now, you can rely on this term of CPR to remind yourself what are the major, if you like, components that manifest itself as a shock state. There would be either a problem in the capacitance, so there would be inadequate volume, or there would be a pump failure, or there might be a resistance failure, i.e. dilatation in the circulation. One important message to take away today, that shocks can coexist and do exist quite often, and the only way sometimes to get out of shock is really to treat, to identify the existence of another type of shock. So you might be focusing on replacing the volume when the patient also needs some inotropy to correct the shock state. So in the normal state, we will have the heart pumping away, and there will be adequate vascular resistance to maintain blood pressure. And then you have the tank or the capacitance holding the blood volume in the circulation. And then when you have a problem with the capacitance, then you might have a drop in the volume or volume depletion in the capacitance, as it happens in hypovolemia. Or you might have the same volume, but the capacitance is vasodilated. So that what we see in distributive shocks. Here you can see you can have either relative hypovolemia because there is loss of fluids into the third space, or actual hypovolemia when the patient doesn't take enough fluids or lose fluids with the sweating and what have you. Or you might have a problem with the vasoconstriction in heart failure and end up having there's volume overload in the capacitance. So the two major types of shock, you can say there's distributive shock and resistive shock. When we say distributive shock, then we would mean a state of high cardiac output associated with low systemic vascular resistance. And this can be seen commonly, obviously, in septic shock is the commonest cause, but can be seen also in anaphylactic, in adrenal failure, and neurogenic shock. Whilst the resistive type of shock, usually it has low cardiac output associated with high systemic vascular resistance. And this is what we see usually in hypovolemic shock, cardiogenic shock, as well as obstructive shock. Now we'll start with the distributive shock, where we have loss of peripheral resistance with an overall decrease in the stroke volume and the systemic vascular resistance. And here, first of all, you'll have low vascular resistance, vasodilatation. This will increase the tank capacitance, and you end up having low blood pressure. And then the heart tries to compensate and will have high cardiac output state. Clinically, and that's the important part, on examining the patient, you'll feel that your patient is quite warm. we usually say warm, well perfused. They have dry peripheries, obviously tachycardic, pounding pulse, and their capillary refill time would be normal or even short. So that's an important way of assessing your patient clinically to establish what is going on or what is the type of shock that you are dealing with. And these are examples of distributive shock. As we mentioned, we add to this liver failure. You can add any third state, really. So systemic inflammatory response syndrome, as we see in acute severe pancreatitis, as we see also post-cardiac arrest, post-cardiac bypass machine. All these situations can give you vasodilatation or distributive shock. Moving on to the hypovolemic shock, and here you will have low volume in the tank, and the heart try to compensate by pumping vigorously, and then to maintain the blood pressure, the blood vessels will have high vascular resistance, and this usually manifests itself as a cold, a clammy, the cold peripheries. The patient would be clammy, tachycardic, and you can see their veins are empty. A few words about stages of hypovolemic shock, because I think this is really important to keep in mind. This is the classification of the American College of Surgeons Committee on Trauma. And here we need to remember that our patient at the early phase might lose up to 30% of their circulation and still have normal blood pressure. When your patients start to have low blood pressure in the context of hypovolemic shock, then probably they are at the class 3, where they have lost more than 30 to 40% of their blood volume. And if they start having confusion, they are lethargic, or their heart rate above 140, then here you can see probably they have lost more than 40% of their volume. A bit of physics again, I'm afraid. And here, the importance of understanding the speed of giving fluids to resuscitate patients. And this is Postilo's equation, which dictates or illustrates the speed of giving fluids, or the flow of fluids into a tube. And we can see here the importance of the radius of the tube, because it will be to the power of 4. And this is a very important point, because even slight change in the radius of your tube, the flow will be hugely improved. And this study illustrated that. So basically, when you are using a 14-gauge cannula, the orange cannula, then you can run up to 236 ml per minute, just flow rate with the gravity. Compare that with 154 for a gray cannula, 16-gauge, and almost 100 ml per minute for a green cannula. But the pink cannula will allow you 64 ml per minute. Remember, when you are dealing with hypovolemic shock, you need to reach out for really wide bore cannulas. So I would say green and above. Because look, if you waste time trying to insert a central venous catheter, then the flow of fluids through the gauge 18 port of the catheter would be only 29 ml per minute, almost a third of what you can achieve with a green cannula. This all to do with the, obviously, why the 18-gauge CVC port would allow only 29 ml per minute, because now we are talking, there's also extra length of the CVC impeding the flow of the fluids in the tube. So please keep this in mind. If you have a hypovolemic shock patient, do not waste time putting central lines. You reach out for the widest bore cannula that you can get and insert it as quick as you can. Moving on to the cardiogenic shock, and here the initial problem would be with the low pump speed, so the heart output or the cardiac output is low, and this will lead to high vascular resistance in a way to compensate, to maintain the flow. And then the capacitance will have high volume. There will be congestion in the circulation because the blood is coming back to the heart but it's not fully ejected, so there will be backward reflection of the fluids, and that leads to fluid congestion. Again, your patient would be usually cold, peripheries clammy. They will have decreased capillary refill time. So when you press at the tip of the finger and release, then it will take more than 3 seconds for the color to come back. And they might have raised JVP. It depends at which stage you catch your patient. Moving on to obstructive shock. Again, some authors do consider this as part of cardiogenic shock, where you have low pump output. They will have, again, high vascular resistance, but the volume in the capacitance might not change, especially in the early phase. Again, your patient would be cold, clammy, with the decreased capillary refill time or prolonged capillary refill time, and usually they have raised JVP. And examples of that, what we see in the massive PE, cardiac tamponade, constricted pericarditis, tension pneumothorax, and mediastinal tumors. This just to illustrate various types of or examples of shock that we have already talked about. And here we come to the clinical assessment. So to assess the patient, you will assess the systemic vascular resistance. You can assess the preload, the contractility, and the afterload. Now, in low resources countries, you might not have the advantage of any tools or many tools at your disposal to assess various parts of the hemodynamics. However, assessing the systemic vascular resistance would be quite easy or easily achieved by checking the skin temperature, the capillary refill time, and the pulse pressure. So this is just, again, to illustrate or to answer the question of yesterday. Your hypovolemic patient, your cardiogenic patient, and your obstructive shock patient, all of them will have cold skin or cold peripheries. They will all have prolonged capillary refill time, and they will all will have narrow pulse pressure. So you might say this doesn't help me much, but at least we have a starting point to consider. So if the patient is coming with a bleeding, obviously you're not going to say he's got cardiogenic shock. And if your patient, there is no obvious fluid loss or bleeding, then obviously, and he's elderly at risk of cardiac disease, then probably cardiogenic shock jump at you to suggest that as a possible cause. Now, if you have central venous catheter inserted, then you will find that the hypovolemic shock patient usually have low CVP. We talked about this yesterday, and we said there's not many causes of low CVP in the context of shock. If the CVP is less than 5, then almost certain your patient is hypovolemic, and it's likely that he will benefit from volume loading. Having said that, in cardiogenic shock, you might have high CVP as well as in obstructive shock. And in distributive shock, it might not be really helpful at all to know the CVP of the patient. If you have the advantage of having a pulmonary catheter inserted, then you will find out that in cardiogenic shock, you will have high pulmonary artery occlusion and pressure or wedge pressure compared to low wedge pressure in other types of shock. If you have a pulse contour analysis device, we will talk about this in our second session, inshallah, then you can see the stroke volume variation being more than 10% in hypovolemic shock patient and possibly in distributive shock patient, but it would be less than 10% usually in cardiogenic and obstructive shock patients. When it comes to contractility, then you will find that apart from the distributive shock, where usually we have high cardiac output associated with low vascular resistance, generally speaking, the cardiac output is really low in the other types of shock. The systemic vascular resistance index, again, if you have a machine to measure it, then you'll see it's high in the cardiogenic, hypovolemic, and obstructive shock, but it would be low in the distributive shock. As we said, it's quite reliable sometimes to assess the peripherals, the skin temperature, the capillary refill time, to as an indicator of the systemic vascular resistance. How do you check the capillary refill time? You can use this way, pressing at the thumb. I usually go for the tip of the finger and assist that, press for a few seconds, then release, and see if the time it takes for the pink color to come back. There's devices and tools to do that, or to, if you like, standardize that. You don't need it unless you are running a study about the capillary refill time. Again, we mentioned yesterday about the skin mottling as an indicator of poor perfusion, and at this stage, usually your patient is deep into his shock. The mottling can be at the peripheries, or can be in the abdomen as well, or around the kneecap. Now, when you are resuscitating your shocked patient, what are the targets that you aim for? Well, we have upstream markers and downstream markers. For the upstream markers, you have the mean arterial pressure, and we suggest, or it's commonly accepted, that MAP of 65 and above is a good target to aim for. However, we mentioned yesterday, you have to individualize the MAP according to your patient's condition. Cardiac output of more than 5 is usually good, or cardiac index more than 3. Stroke volume variation, try to keep it 10 or less. And if you have a pulmonary artery catheter in situ, then try to maintain the wedge pressure between 8 and 12. Now, the downstream markers, which is really the reflection of perfusion, then you try to get the lactate cleared by 10% per hour or until normalization. And mainly in the context of trauma patients and hypovolemia, then base excess correction would be a good target as well to reflect adequacy of resuscitation. So, common question, when do we stop fluid resuscitation? We did talk about this yesterday. We stop resuscitation when there is evidence of fluid overload, for example, pulmonary edema or significant positive fluid balance. Then at that time, you need to ask yourself, is it wise to continue giving fluid resuscitation, knowing that for each 1 liter increase in the fluid balance, there would be 10% increase in the mortality in the first 72 hours of septic shock patients, as we saw yesterday from the SOAP study. If you have an advanced hemodynamic monitoring device that's giving you the lung water index, then probably you should keep it below 10 and stop giving fluids when it reaches to 10. If you have a CVP and a cardiac output monitoring device at the same time, and you see that the CVP is going up whilst the cardiac output is going down, then that's another time where you should really stop giving fluids. Or if a PA catheter is in situ and it's already getting to 20, then probably you have gone too far with the fluid resuscitation, because all now going into the pulmonary tissues. Right, a few quick cases and we'll be done with the shock syndromes. So this is a 34-year-old patient involved in a motor vehicle accident, arrived to emergency room with blood pressure of 70/45. Heart rate is 142. He's cold and clammy. So the question to the audience, which of the following is typical in hypovolemic shock? Would you get high SVR, high cardiac output, high oxygen delivery, or normal wedge pressure? Any takers?
High SVR.
Right. High SVR. I didn't know who said that, but yes, well done. So they will have a compensatory.
Me, Dr. Mohammed Salahuddin.
Muhammad Salahuddin.
Yeah. Dr. Salahuddin is a United Hospital.
MashaAllah. Well done, Dr. Muhammad. So yes, they have high SVR, and this is just a re-illustration of what we talked about. Usually these patients start having low preload, and that leads to low stroke volume, low cardiac output, low blood pressure, And as a compensatory mechanism, they will have high heart rate and increase in the peripheral resistance. And that's what you find if you measure the cardiac output or the systemic vascular resistance, the wedge pressure, and the end-diastolic volume. And these are examples of hypovolemic shock. It can be hemorrhagic, or it can be fluid depletion, or it can be increased vascular capacitance, venodilatation, as we see in sepsis and in toxins, where the patient might have third spacing. Case number 2, a 54-year-old with acute onset chest pain arrived to emergency room with blood pressure of 70/50 and heart rate of 140, cold, clammy peripheries, decreased capillary refill time. So the question, which of the following is typical of cardiogenic shock? Do you get low SVR? Do you get high cardiac output? Do you get low oxygen delivery? Or do you get low wedge pressure?
Anyone from the participants?
Low oxygen delivery.
Lower oxygen. Again, Dr. Muhammad, mashallah. Come on, everyone. It's just to try keep you engaged. I'm sure you all know the answer. Low oxygen delivery is the correct answer. Well done. So here the patients start having low contractility, and this leads to increase in the preload because of left ventricular increased size. Myocardial fiber shortening leads to increased preload. Stroke volume will go down, cardiac output will go down. As you'd expect, blood pressure will go down. As a compensation, you'll have tachycardia and increased systemic vascular resistance. Again, these are possible examples of cardiogenic shock. Could be myopathic, myocardial contusion in trauma cases, myocarditis, different types of cardiomyopathies. It could be drugs and toxins related. It can be mechanical or arrhythmic. Case 3, 67-year-old with fever, chills, shortness of breath, and ugly-looking abdominal wound arrived to emergency room with blood pressure of 70/30 and heart rate of 135. Skin is warm, and capillary refill time is 2 seconds. So again, the question, which of the following is not typical of sepsis? You will have low systemic vascular resistance, high cardiac output, low oxygen delivery, or low wedge pressure. We are saying not typical of sepsis.
Low pressure.
Who is going?
So I missed that. What was that? What was the answer?
Dr. Mohammed Salahuddin.
Yeah, low waist pressure. D.
It says not typical of sepsis.
Low oxygen delivery. Low oxygen delivery.
Yeah, probably that's the correct answer. So we are talking not typical. Usually in septic shock patient, they have high delivery of oxygen, but the problem is in the consumption. And as we illustrated in the earlier slide, one of the earlier slides, that you will see the oxygen consumption start to decline early on in sepsis. And here there is a problem with the peripheral resistance, and then you'll have increased contractility, increased stroke volume, increased heart rate and cardiac output, but you have low blood pressure. And these are examples of the distributive shock as we illustrated earlier. The obstructive shock, you will have increase in the afterload that leads to decreased contractility, increase in the preload, stroke volume will go down, cardiac output will go down, arterial pressure will go down, and as a compensation, you'll have high heart rate and high systemic vascular resistance. Some people divide the obstructive shock mainly related to the afterload and preload. More or less, they are the same, apart from the end-diastolic volume. And these are examples of extracardiac obstructive shock. Now, we just need to reiterate what we said yesterday, that optimizing the macrocirculation does not equal to optimum microcirculation. So you might get the map to the target that you wanted, say 65 millimercury, but still your patient might continue to deteriorate, especially if they got to a stage where the mitochondria shut itself on itself, stop taking any oxygen for aerobic utilization or generation of energy, and that would lead to perpetuation of shock state. On the other hand, optimum microcirculation usually, but not always, leads to optimum tissue perfusion. So really, if we can assist the microcirculation early on and see if our patient is improving, then that would be, in my opinion, the best way forward. And that's why I quite often rely more on the perfusion indicators more than just the macrocirculation indicators or reflectors. So with this, we will have any questions before we proceed to the advanced hemodynamic assessment.